We move on to the small intestines now. So this is the major organ of digestion and absorption. It makes up the majority of your alimentary canal. So remember, alimentary canal was, we said, about 7 to 8 meters long. 2 to 4 of that, depending, is your small intestine. And we have subdivisions. There's the duodenum, not duodenum. I know people still say duodenum, but it's duodenum. And then there's jejunum, and there's ileum. Again, pay attention to the fact that it's ileum and not like the hip bone with two eyes, right? Make sure that you can follow the pathway of food here. You start at the oral cavity or the mouth. Then we're going to move into the pharynx. Then we're going to move to the esophagus. We're going to come through the diaphragm, move into the stomach. From the stomach, we're going to go to the small intestine. The very first section is just this little C-shaped loop right here, which is the duodenum. And then once we come under this part of the large intestine, the transverse colon, we're going to come into the top section, which is the jejunum, and then it gets smaller. And I'm sure you can see down here, this is much smaller than this section up here. So you move from duodenum to jejunum to ileum, and then from ileum, you're going to go into the cecum, which is the first part of the large intestine. When we mentioned the blood supply, we've already talked about the superior mesenteric artery. This is the major artery that's going to feed the majority of the small intestines. It is a little bit more complicated than that. Most people think of superior for small intestines and inferior for large intestines, but they both kind of overlap. So for right now, think superior mesenteric artery, mostly small intestines, but it also does large intestines as well, or supplies oxygenated blood to the large intestines. For the veins, remember that the small intestines are going to drain into the hepatic portal vein. So the superior mesenteric vein drains into hepatic portal. That goes into the liver. The liver cleans or detoxifies the blood, and then it enters back into the inferior vena cava via the right and left hepatic veins. We also have nerve supply, both parasympathetic and sympathetic, so you have that dual innervation to the small intestines. So what's special about this duodenum section of the small intestine? Well, we've already seen this is where the bile duct and the main pancreatic duct meet. So remember, the bile duct is depositing concentrated bile to break down fats. The pancreatic duct is dropping off pancreatic juice to elevate the pH, and also digestive enzymes to finish breaking down the chyme as it comes from the stomach. This area is, they say it's the proximal part for nutrient absorption. So absorption is happening in the duodenum, but you also have a lot of action where you're dropping off the bile and the pancreatic juices. You're going to see microvilli. Remember, those are finger-like projections. They used to be called brush border cells. You're also going to see villi, which are, again, finger-like extensions of the mucosa. And then you're going to see these circular folds. And all of these structures are going to help move the chyme and allow for increased absorption. So remember, those finger-like projections, the more surface area you have, the more absorption can occur. I put this image back up so that we can see the circular folds. And then also in here would be the finger-like projections, the villi and the microvilli. Here's an enlarged version of that, so you can see we have to have muscle because we're going to be doing alternating contractions and also segmentation. You can see the circular folds. Those are going to help move the chyme through the tube system along with the muscle contraction. And then you can see that we've increased the surface area here. Instead of just having a straight line, we have these villi or brush border cells, right? So we have these villi that are forming these loops, and that means we have more points of entry or more absorption surface area than if we just had a straight line. And then you can see that these are going to be absorbed in the mesenteric veins in blue, and that's going to go to the hepatic portal. Need to bring up chemotherapy drugs and their targets. So basically, if somebody is taking chemotherapy drugs to fight cancer that's growing and spreading rapidly in the body, the chemotherapy drugs are targeting rapidly dividing cells. Cancer cells are rapidly dividing, but so is the epithelial lining of your GI tract. Kind of think of it as the food is moving through, as the chyme is moving through. Just like when I talked about the mouth, when you put food in your mouth and you chew it, some of the epithelial cells in your mouth go into the food. It's the same thing here. You're basically dragging the food through the small intestines, and some of that epithelial lining is going to come off into the chyme that you're moving through the intestines. So these rapidly dividing cells, they have to replenish themselves. If every time you eat, you're scraping off some of the cells, they are also rapidly dividing. So cancer cells that are rapidly dividing and healthy GI tract epithelium that are rapidly dividing are both affected by chemotherapy drugs. That's why you'll see many patients that are undergoing chemotherapy have issues with diarrhea, with food absorption, with wanting to eat, right? So all of those things, it's kind of all leads together, right? You have to have rapidly dividing GI tract epithelium because they're constantly being scraped off and you need to replenish them. This is another nice thought, right? You have to be secreting intestinal juice. So as the chyme is moving through the small intestines, you have to have some fluid in there, right? So intestinal juice, we secrete a couple of liters a day. The major stimulus for the production is the acidic chyme. So we had the chyme coming in that was highly acidic from the stomach. It mixed with the pancreatic juice, which was more alkaline, but we still have an overall acidic chyme, and that's going to trigger this intestinal juice secretion, right? So it's mostly water. There's very few enzymes in it. It does contain mucus, and basically the entire point of the intestinal juice that's being secreted by the mucosal layer is there to facilitate and transport nutrients. We have our summary slide again. So we have chyme from the stomach. We have partially digested carbohydrates and proteins. We have undigested fats. So up until now, maybe we broke down some of the fats in our mouth from the saliva, but we haven't had a big rush of fat breakdown. So the chyme is going to mix with the bile and the pancreatic juice. All of that is happening in the duodenum. The food is going to move from the first section, or the most superior section of the small intestine, the duodenum, and move into the jejunum. The entire time that the food is moving through the small intestines, where does it go after jejunum? It goes to ileum. We're going to have segmentation and peristalsis happening. So you're going to have adjacent and non-adjacent segments of the tube contracting, pulling the food apart, mixing, so that absorption can happen all along the small intestine. Looking at the large intestines here, we've removed the small intestine. We can see the ileocecal valve. This is where the ileum is going to merge with the cecum. The ileum would be small intestine, the cecum would be large. So there's a valve here as we dump from the small intestines into the large. Here we have the cecum. Then we have ascending colon. We have transverse colon. We have descending colon. We have sigmoid colon that makes this S-shaped. Then we have the rectum, the anal canal, and then we'll have the opening, which is the anus. So these three highlighted structures are structures that are specific to the large intestine. We don't see them anyplace else. So this tinea or tinea coli, it's this band of smooth muscle here in white, and it stays partially contracted and it pulls on the tissue of the large intestine, and it forms these little pouches. It's almost like pulling a string too tight, right? Elastic on an elastic waistband. If you pull the string too tight, it kind of puckles. That's what we're seeing here with these haustra or haustrum. Haustrum is one. So these little pouches are created by this pulling of this smooth muscle. And what happens is when the chyme dumps into the cecum, it'll move from one haustrum to the other, and this is happening because of peristalsis, again, those alternating contractions. The other thing are these little appendages. These appendages are going to fill with fat. Something that I think I'm going to mention later, but since I have the image in front of me, I'll explain it to you. This is why fiber is really important in your diet, because fiber is indigestible, right? We can't break down some of these really complex carbohydrates. So if you're not eating a lot of fiber, you're not scraping the large intestines as the feces is moving through. So you can have little pockets here where feces gets trapped. And then if the feces is trapped, bacteria set up shop and they start multiplying. So if you've heard of diverticulitis, it's a little outcropping or pouch of feces that's stuck in your large intestine. More anatomy terms, I just mentioned the cecum. That's the very first section where the ileum of the small intestine meets the large intestine, and off of the cecum is the appendix. You do not have to call it the vermiform appendix, you can just say appendix. Then we have the ascending, transverse, and descending, and sigmoid colon. Then we have the rectum, and there are some valves here that stop feces from being passed when you pass gas. And then the anal canal, we're going to look at these two different sphincters. So we have an internal anal sphincter and an external anal sphincter. And something to note that we'll come back and talk about is the internal anal sphincter is smooth muscle and the external anal sphincter is skeletal. The figure from your textbook shows you the anal canal. So this area is the anal canal. We see the opening, which is the anus. We see the levator ani. Do we remember levator ani? From 201 muscles, it's going to elevate the anus. So when this muscle is contracted, it's going to pull on the anal canal and lift it up. And this pressure change is what's going to allow the feces to move from inside the body to outside of the body. I wanted to show you the valves that are here, the rectal valves that are stopping feces at certain points. And then I want to show you the muscles. So these three groups of muscles on the outside, these are external anal sphincters. And then here, the ones that line or touch the anal canal, these are the internal anal sphincters. I also want to mention these hemorrhoidal veins. So all of these veins here that line the anal canal, you can have issues where blood can pool due to too much pressure, like you're straining too much to defecate, and that blood can fill these veins and then they can protrude or hang outside of the anus, and that's where that term hemorrhoid comes from. I feel like we just keep mentioning inflammation with every organ or structure that we talk about. Remember the appendix hangs off of the cecum, that very first section of the large intestine? Well, we can have appendicitis. So if there's any sort of blockage, feces gets trapped, if there's an infectious bacteria, there's really no place for it to go. We have to be careful because this is inside the peritoneal cavity. So if the appendix fills with bacteria and toxins and it explodes or ruptures inside the peritoneal cavity, well, now you have infectious bacteria all over the intestines and any of the intraperitoneal organs. A couple of things to mention with the functions of the large intestine. Basically, it's going to reclaim vitamins, water, and electrolytes. So this is kind of our last ditch effort. Anything that we might need, we need to absorb it at this point because we're getting to the point where everything else is going to be released from the body as indigestible food residue, which would be feces. Something to mention, the colon is not essential for life. So people have had issues where their colon was damaged or they had colon cancer. You can remove the entirety of the colon and still survive. They used to do, or in some cases they still have to do, an ileostomy. So they take the ileum of the small intestine and they connect it through the abdominal wall and you collect the feces on the outside of the body. There have been and are some other procedures that can be done, especially depending on the age that the colon is not working or destroyed or infected. I've heard of some cases where they actually take the ileum and they connect it directly to part of the colon that's still intact, like the sigmoid colon or the rectum, and these people can defecate normally. They just don't have the ascending, transverse, or all of the descending colon. We need to mention that there are good bacteria in our intestines that help us ferment or break down indigestible carbohydrates. So remember cellulose and some of these things that we can't break down. Well, we have some bacteria that can break part of it down. They can also, the bacteria can help us synthesize some of the vitamin B complexes and vitamin K. And both of these are essential. So vitamin K, if you remember, is needed by the liver to produce clotting factors. And then these B complexes are important in cellular respiration. The bad thing is that sometimes they can release irritating gases, right, or acids, and make our intestines not function or feel like they're not functioning right. So it's always this balance. You don't want the bacteria to get too high. You don't want them to get too low. So I tell people we even have E. coli in our small intestine. It's not the same as if you go to Burger King or some fast food place and you eat a burger contaminated with E. coli. That's not the same. Right? That's too much bacteria. It's really interesting. They're starting to look now at your microbiome. So they're looking at what bacteria is in your gut and is it based on the foods that you consume? So let's say you have 10 different species of bacteria in your gut. If you have a high meat diet, maybe 5 of those 10 are really, really high and the other 5 are really low. And then if you're to switch to an all plant-based diet, now you've got the other 5 are reproducing and really high because they have their fuel source that they need. So now we're trying to look at the food that you ingest, the genetics of your body, how the bacteria affect, or how the food that you eat affects the bacteria, and then how that bacteria affects you. So they've also done some studies that the bacteria in your intestines can release hormones and chemicals that could affect whether you're depressed or whether you're happy. So there's probably going to be a lot more talk in the next 10 to 20 years trying to look at how all of this comes together to affect the body as a whole. So we need good bacteria in our intestines, but sometimes the bacteria mutate. So there are some bacteria that are resistant to antibiotics that we have. So C. diff is one of those. It's a bacteria that can survive antibiotic treatment. It can flourish. It can cause inflammation in the colon. It can lead to perforation in the bowel. It can cause sepsis because it can then be in the peritoneal cavity and spread to other organs. So we do have to be careful. This is why we had that whole craze where we're handing out antibiotics like candy, even if we had a viral infection when the antibiotics won't work. And now they're kind of trying to back off, and they usually want to test and make sure that you actually have a bacteria and that we can treat it with whatever antibiotic we're going to give you rather than just handing out antibiotics. It's because we have created or allowed some of these resistant bacteria to form due to our overuse of antibiotics. Here's what I mentioned earlier, diverticulitis. So inflaming or rupturing of the large intestine. Diverticulosis, if you have the diverticula, basically that pouch, right? So you can have a narrowing of the colon. You can have herniations of the mucosal layer. You can have these little pockets of feces trapped in the large intestine, and this can be life-threatening, especially if they leak into the peritoneal cavity and start infecting all of the other abdominal organs. Now we get to talk about defecation. So mass movements, forcing the feces from the descending colon through the sigmoid colon into the rectum. So your parasympathetic nervous system stimulates contraction of the sigmoid colon and the rectum, relaxes the internal anal sphincter because that is involuntary. You have conscious control over your external anal sphincters. So think about this for a second. Do you remember what I said? Internal anal sphincters were smooth muscle. Those are involuntary muscles. What about external anal sphincters? I said those were skeletal muscles. Right. So if you are driving in your car and you're, oh my God, I have to go to the bathroom. I have to defecate right now. What's stopping you from doing that? The internal anal sphincters are open. They're like, ooh, gotta go. And you're contracting your external anal sphincters. You're like, nope, not now. because this is skeletal muscle that I have control over. So eventually, if you let go of your external anal sphincters, you're going to contract and expel the feces. So another thing that assists in this is abdominal pressure. So we call this the Valsalva's maneuver. So basically the closing of the glottis, that's the opening in the larynx, right? The contraction of the diaphragm and the abdominal wall muscles, and it causes increased intra-abdominal pressure. So just like when we talked about decreasing pressure in the lungs, right? Decreasing the volume cavity to increase the pressure, or making the thoracic volume cavity larger and decreasing the pressure, right? So what we're doing here is we're pushing down on the diaphragm and we're increasing the pressure in the abdominal cavity. And if the pressure is high inside the abdominal cavity compared to outside, the feces is going to flow from the rectum to the anal canal and out of the anus. We also have that levator ani muscle that's contracting and causing the anal canal to lift up superiorly, and that also allows the feces to leave the body. Something to mention, why is diarrhea so bad? Why is watery stool, why can it be life-threatening? And it has to do with dehydration and loss of electrolytes. So in order for you to do absorption, you want kind of slow and steady. We're going to see this again when we get to urinary. We don't want to just push all of the feces through our intestines as fast as possible because you don't have time to reclaim the items that you want to keep. So diarrhea, too much water, floods the intestines, and you push everything out too quickly for you to reabsorb the good stuff that you want, right? So we want to reabsorb potassium, we want to reabsorb sodium, we want to reabsorb calcium. All of those are necessary for setting up that resting membrane potential. And then we have to have water because remember, water is a major solvent. A lot of reactions happen in the body because we have water present. So both of these things are bad if you are too dehydrated or you don't have enough electrolytes to maintain that resting membrane potential or any chemical reactions in the body. What are the mechanisms of absorption? So we have digestion, right? We're breaking down large molecules, macromolecules, right? Polymers into monomers, small enough for absorption. So we can't absorb the big molecules, we got to break it down. So that's why we've been doing all of this mixing and churning and mechanical and chemical digestion. We have to have enzymes that are going to carry out hydrolysis or hydrolysis. Water is going to be added to break the chemical bonds. We have that large carbohydrate and we need to break it up into individual glucoses. And then we need to absorb that individual glucose. Most of the nutrients are absorbed before the chyme reaches the ileum. So the majority of absorption is happening in the duodenum or the jejunum. I know I keep talking about these 4 biomolecules, but I want to make sure that we realize how critical they are. So what are we doing with carbohydrates? We're breaking them down into monosaccharides. That's just one sugar, right? We want one glucose. We cannot take glycogen, many glucoses. We can't do cellular respiration with that big, large polymer. We need just one glucose molecule in order to start the process of cellular respiration. So remember, carbohydrates are broken down into simple sugars by amylase. Proteins, we're going to break them down into amino acid monomers. Lipids, we're going to break down triglycerides into fatty acid tails. And then nucleic acids, we want to break those down into single nucleotides. So what's the whole point of breaking down these large molecules to get the smaller ones? Well, now we can reshuffle the smaller monomers and make our own proteins, copy our own cells, copy our own DNA by using the nucleotides. We can use it as fuel. So we'll talk more about this when we get to nutrition. Just realize that the whole point of this exhaustive process is to take these really large polymers and break them down into smaller monomers that we can then reshuffle and use to make our own molecules, biomolecules. In the small intestines, we can absorb some vitamins, and other vitamins are absorbed in the large intestine. So in the small intestine, we can do vitamins A, D, E, and K. A has to do with the retina, like vision, carotenes. Vitamin D is going to help us absorb calcium. Vitamin E's are protective in nature. They protect cell membranes, like to neurons. We have vitamin K. Remember, that's going to help make clotting factors in the liver. So we have fat-soluble vitamins that are absorbed in the small intestines, and they kind of get enveloped because they're fat-soluble. To get through the water into the small intestines and be absorbed, they have to be packaged in these micelles. It's kind of like sticking the vitamin inside this vesicle and then transporting it into the small intestines. So the water soluble, we have vitamin C. This is necessary for like skin, collagen. If you don't have enough vitamin C, your skin, connective tissue starts breaking down, you get scurvy. And then the vitamin Bs are all necessary for metabolism. So various stages of metabolism. Think of cellular respiration. You have to have many of the different vitamin Bs that we have. Remember, vitamin B12 specifically binds with intrinsic factor, and this is going to help us make red blood cells. We also have large intestines that can absorb vitamins K and B. So that should tell you also redundancy, right? Every time I said if you have two pathways that you're going to reabsorb a vitamin, that should tell you how important it is. Well, maybe I didn't say vitamins, but I said if you have two pathways, it probably means they're important. So being able to absorb vitamin K and B in both the small intestines and the large should tell you that this is important. We also have a lot of electrolyte absorption happening in the small intestines. So iron that you need to make heme, right, for red blood cells, calcium for bones, those are absorbed in the duodenum. You're also going to have sodium and potassium and calcium. These are all going to be absorbed in the small intestines as well. The majority of your water is absorbed in your small intestines, but we do have some that's also reabsorbed in the large intestine. And something that we'll see and that we've talked about already with blood pressure is usually there's some sort of coupling. So water uptake is coupled with solute uptake. We do have some clinical homeostatic imbalances where people are not able to absorb a particular item, like maybe you're not absorbing enough calcium, maybe you're not absorbing enough B12. So malabsorption can be caused by anything that interferes with the normal absorption in the small intestines or the large. So it could be maybe your gallbladder isn't functioning properly and you're not secreting enough concentrated bile. Maybe something's wrong with your pancreas and it's not able to secrete the pancreatic juice or the digestive enzymes. Maybe somehow your intestinal mucosal layer is damaged and you're not producing enough mucus. Maybe there's a bacterial infection that's disrupting the absorption process with those microvilli fingers, right? Maybe some antibiotics are killing some of the good bacteria that are helping you digest some of these food sources to get the vitamins out. Or maybe you're having some sort of immune reaction. It could be to gluten, it could be to specific types of food. Imagine if you have an immune reaction, you have inflammation, you have an overproduction of mucus, or you have a lot of white blood cells flooding an area, you're not going to be able to absorb food as well at that area. And of course, we have to end on a sad note and talk about aging. Everything declines with age, right? So the activity in your gastrointestinal tract is going to decline. You're going to make less digestive juices. You're going to absorb less efficiently. Your muscle contraction is going to slow. So you're going to have less movement, less peristalsis. You're going to have a decline in the frequency of bowel movements. Also, smell and taste can become less acute as you get older. We talked about periodontal disease, so having too much bacteria in your mouth and plaque buildup and how that can affect maybe your increased risk for heart disease or stroke. And then we talked about diverticulitis. So if you're not consuming enough fiber and you're not cleaning or scraping out your large intestine, you can have these little pouches of feces collect, and then bacteria. You can also have some of those external anal sphincters not working so well. So that voluntary control of feces being removed from the body. If those external anal sphincters aren't working really well, as soon as the internal open, the feces comes out, whether you want it to or not. We see a cancer increase as we get older, just because these cells are dividing multiple times, and also because they're exposed to the external environment. So the more the tissue is exposed to the external environment, that means viruses and pathogens that could eventually affect the cell and cause some sort of damage. Well, I hope you had fun. This is kind of long. I understand that. If you can just focus on the functions of each system and some of those key terms, I think you'll be okay. Bye, guys.